going to record to my computer, and let me get the screen shared so we can get going. There we go. All right. So I want to go through today and just talk a little bit in more depth about lipids. For anybody who's followed with me in my practice, most of you have had a little bit deeper dive into lipids, but I want to stress for those of you who are not typically patients and or who follow with the primary care, why it's important to make sure that you're taking that next step and looking just that little bit deeper into what's going on with your lipids. You know, a lot of people are told, oh, your cholesterol, your good cholesterol, bad cholesterol, those ratios are a little bit off, but they're not too bad. Actually, I think we've got another couple of people joining us, so we'll let them get joined here real quickly, and then I apologize, we will start over. So again, hello, and thank you for joining me. Today, I'm going to go ahead and go through and talk a little bit more about why it's important to do a little bit deeper dive into lipids. For anybody who's followed in my practice, you know that I usually take a look at a little bit more than just your basic cholesterol levels that you get with a regular general annual physical. And we're going to talk a little bit about why that's not enough. And as adults, why we need to take that extra little bit of a deep dive. And I'm just going to give you some examples of that today. For those of you who followed with me, you probably had those levels looked at. If you have them in front of you, or if you have a way to look at them, that's great. I did explain earlier, just was commenting, I'm at a medical conference. I'm doing my obesity medical conference this week. So I'm in the middle of a hotel room. So if it looks a little shady, that's why I'm here. So for those of you that don't know. So anyway, we're going to go ahead and talk a little bit about lipids and why it's important, not only just to look at the basics, but why we want to look a little bit deeper. So let's go ahead and take a look there. There are basically 4 parts to heart disease testing. In my very first talk through my stress seminar, we talked a lot more about sudden cardiac death, which unfortunately is not really related to cholesterol at all. It's really related to our stress levels and adrenaline surges that we get that create contraction zones. So if you haven't had a chance to, if you weren't able to be at that discussion, we will be putting that up on the internet on our website page as well. So you might want to look for that sudden cardiac death one. Really important to look at. This is the other side of that heart disease. And this is when we start talking about vessels, blood vessel disease, and blockages with the heart and other diseases that we can end up with the heart. But there are 4 main parts to testing that we want to look at. First, we want to look at the lipids, cholesterol, HDL, so that good cholesterol, bad cholesterol. We'll talk more about those in depth. But what we want to know is, are we creating problems in the vessels? And that's the bottom line. As mammals, we make cholesterol. All of us do. If I check the blood of a horse or a cow who eat grass all day long, they're still going to have cholesterol. Why? Because we use it for a lot of physical things in our body. That's the reason our body makes it. And for those people who watch Survivor shows, those people are never trying to lose weight. They're always trying not to die. But one of the biggest things out in nature was them trying to get enough of the fats, or especially the healthy fats. It's really tough to come up with enough of that. And so our body can become very good at recycling or reabsorbing cholesterol once we excrete it. So realizing that there are some of us that are better reabsorbers than others, some of us are bigger producers than others. But again, it's all something that we need. I don't care how much you have, as long as it's not doing anything bad. But if we have more than we need and it's doing something bad, we definitely need to reduce that amount so that we're not creating problems. Cholesterol, we'll talk a little bit about what it can do and what impact it has on the blood circulation and blood flow. And we'll talk about that more in depth in just a little bit. But again, most of us have looked at those panels where we look at your total, your bad cholesterol, good cholesterol, triglycerides, and your non-HDL, which are all of the bad ones put together that are not the good ones put together. So we'll talk a little bit about those functions of those different ones, but this is mostly what people get, hopefully not these bad in numbers. But those are usually what you get looked at in a regular primary care. They'll sometimes look at the ratios of one to the other, but they don't look any deeper than that. So we're going to talk about why it's important. The other thing that we want to know is the 2 things that are most important to me is the cholesterol doing anything bad? And are we at risk for it sticking on to the vessels? So if I have too much inflammation, or if I'm shredding the linings of my vessels too much, if I have things that are shredding or creating problems, that makes those vessels more sticky. It's just like my skin. If I rub up against a table or a door frame, SI can come through, or CSI can come through and tell you I was there, I've left cells, but I'm turning that skin over all the time. It's not a problem. But you can imagine if I took sandpaper and started rubbing it on my arm all the time, that arm would no longer look healthy. It'd be weeping, it'd be sticky, I'd form crust and inflammatory secretions all the time, just trying for my body to keep that area healthy. Well, the same thing happens with the blood vessels. We're meant to have a little bit of scraping and scrubbing against the sides of the walls, but it's also meant to be in a limited amount. And if we have anything that impairs our ability to heal, or if we have anything that tears it up more rapidly, or a combination of both, we can magnify that problem and we can get a lot more inflammation. So we're going to talk about how do we look at that inflammation and what can we do about it. One of the other pieces of the metabolics, and the metabolics are one of those things that add to the shredding of the vessels. Glucose is a very sharp molecule. If we have elevated insulin or glucose, even long before we have prediabetes or diabetes, too many of those sharp molecules, again, mean too much shredding, which leads to too much inflammation in those vessels. So we don't want to be having that happen as well. So we'll look at that. And then the genetics piece. There's several things that genetics plays a role with. One of them is our ability to convert our vitamin Bs into the active form. Most of my patients, we've talked about that in my office because it makes a difference as to whether or not we can let go of fat. But also those Bs are responsible for how we help or heal or repair cell membranes and our RNA and DNA. And so if we don't have those Bs in the methylated form, methyl B12, methylfolate, we don't heal and repair as efficiently. If we don't absorb fats appropriately, either because of digestive issues or because of genetic issues that we are prone to not being able to absorb or handle our fats, those also can impair our ability to heal and repair those linings. So that can get in our way. Also, once we start talking about what kind of medications do we want to take and how much of them do we want to take, there are some factors that make a difference as to whether or not we absorb those, but more importantly, whether we can eliminate them appropriately and whether they'll build up in our tissues and whether we end up with problems with those medications creating more side effects than benefit. So again, genetics can play a role, and there's some testings that we can do if we feel like it's appropriate or there's a history that suggests it. I'm sorry. So we'll go ahead and look at that. So first of all, with cholesterol, let's look at the types of cholesterol. There's what we call good cholesterol or bad cholesterol. And I describe good cholesterol, or the HDL, as having maids to clean up the house. So LDL is the bad cholesterol. It's the one that can stick itself along the linings of those arteries, and it packs itself in, like we talked about a second ago with that inflammation. When we talk about those roughened patches, that cholesterol or the bad cholesterol is what sticks along there. If you can imagine, the bad cholesterol is going to be like somebody coming into the house and picking up a huge armload of underwear and socks and trying to run through the house to get to the laundry room. The problem is they're carrying so much they can't hold it all. And so they'll drop some here and drop some there. That's LDL. When we have the big fluffy LDLs, they're just carrying more of that lipid than they can handle, and they just drop some along the way, and it sticks against those sticky patches in our vessels. HDL is kind of like the person that comes up behind him and says, don't worry, I've got you. I'll pick this up, pick that up. So it comes along and kind of acts like the Pac-Man of our vessels. It kind of cleans up or picks up along behind that LDL that's dropping off all that lipid. HDL picks up a bunch and then takes it to the liver, drops it off, and then comes back and follows them around again. So HDL is kind of like having enough maids to clean up. So when we look at HDL, so HDL kind of comes along and it helps pick up or pull that up. So you've got this one that's dropping it off, and then you've got this HDL that's kind of helping pick it up and take it and get rid of it. So we want to make sure that we're minimizing that plaque, and HDL is one of those, kind of like I said, the Pac-Man of the vessels, and helps clean up and pick up regularly. So we have to have enough good cholesterol. The problem is not everybody has healthy cholesterol. Good cholesterol. So the HDL, if you can imagine, is kind of that yellowy piece there, and it goes around and picks up that greenish stuff, which is the LDL or the bad cholesterol. You want an HDL that can pick up more and more and more of that, and you want it to be able to pick up a ton, drop it off in the liver, and do it again and circle around and around and around. The problem is if we have HDL that is not real strong. So you look at this person here, their HDL is picking up here. They don't have many this size, or this size. So again, they don't have really strong ones. It's like hiring some 81-year-olds to come in and clean your house. They could pick up a few socks and underwear and they take them to the laundry room and drop it off, and then they come around and pick up some more. But you're going to not going to get the effective cleaning that you would expect. And one of the problems for women is we used to look at 50% of women that showed up in the ER. We said, yeah, with a heart attack, we said, yeah, we saw this coming. But the other 50% were like, what the heck happened? Well, the problem was when we looked at those women, we look and their lipids didn't look that bad. So what were we missing? And oftentimes their LDL was a little bit off, but their HDL was really good. And so we said, your ratios are great. You've got plenty of HDL to clean up after that bad LDL or those teenagers dirty in the house. We've got plenty of that. So what's the problem? Well, if they're HDL, they have plenty of it, but what they have is not really working and it's not that effective. We're giving them false reassurances that HDL is really helping. So again, if you're in the position of having a mildly elevated LDL and people are saying, but you've got plenty of HDL, you really want to get at least once, look at that HDL map. It's genetically determined to a large part. We can have some impact on our HDL. There are things that I can do to help facilitate making your HDL work better. And that's why it's important to ask the question, but we also don't want to lean on or rely on that if it's not really doing the work we think it is. So if you are relying on a higher HDL to help you with a borderline LDL, you want to make sure that you've always looked at least once at this HDL map to confirm that you really have good functional HDL. If you it'll keep you out of trouble much better. If you don't, then you need to work on that and not just lean on that for your repair, your heal. So the other part is cholesterol, the bad cholesterol. So the question is, do we have too much cholesterol in the bloodstream? And then what do we do about it? Well, it's important to realize that cholesterol, we make it in the liver. And so the liver then makes that cholesterol and puts it into the bloodstream. Some of us are bigger producers than others. Some of us, when we were 18, we weren't making that much. And as we get older, our genetics predisposes us to making more and more of that cholesterol, and or we're turning less of it over because we're not building the body into the, and using that to create healthier tissues like we did when we were younger. So with the liver, it's a matter of production. That has nothing to do with what we eat or how we eat it. It has everything to do with our genetics and whether or not we're using or utilizing what we have in the bloodstream effectively. So the question is it what I'm producing? Because if it is, me telling you just to eat better and exercise better has no impact or very, very little impact on that amount of cholesterol that we have. In addition, our liver makes bile out of cholesterol, and then we excrete it into the intestines, and that bile helps break down our food. It helps us allow us to absorb fats more appropriately. But that bile gets mixed with that food and we help digest the fats. And then as the food goes down, we reabsorb those fats, but we also reabsorb a lot of that cholesterol with it. And then we recycle and reuse that cholesterol. Recycling is great when we used to live in the jungles and couldn't find enough of those fats. But when we have too much of it, recycling is not a good thing, right? So if we're a big recycler, we can just shut down recycling and we can actually lose a lot of it. And again, most of that has to do with how we recycle, not necessarily what we eat. So again, does eating way too much saturated fat make a difference? Absolutely. Does it help to eat just a low cholesterol diet? Not necessarily. But if we are big reabsorbers, sometimes just blocking that reabsorption can dramatically reduce our cholesterol. So the question is this a production problem or is it not? And so one of the things that I like to look at is looking at what we call a cholesterol balance. The cholesterol balance test will look at whether or not you are a bigger producer or you're a bigger reabsorber. And so there are two different types that are produced in the liver. And once we've converted that into things, we make it into these different forms. And the beta sterols and camphoterol are the ones that we reabsorb from the gut. So if these numbers are high, we're a big reabsorber. If these numbers are high, we're a big producer. In this particular person, we could impact some with shutting down production. We could also do things to help bind it in the gut and can make a big difference by hitting it from two sides instead of hitting it harder and harder at one side. The other thing that's interesting is sometimes when we put people on a statin or something that shuts down production, sometimes the body will compensate by increasing absorption because it says, well, we're not making as much. We should really hold on better. So when we find that we're not getting all the results we want with the statin, sometimes people are going up and up and up with that medicine, whereas sometimes they just needed to then block the reabsorption, and that combination might have worked better. So again, watching whether or not you're producing, reabsorbing, or combination can be really helpful in guiding therapy. And also understanding, do I just need to still continue to try diet and exercise to try and manage this? Or am I really just a big producer and I'm wasting my time on doing that and allowing more and more lipid to build up in the meantime? It was interesting, they did autopsies on 18-year-olds during the Korean War, which is tragic in and of itself. They were doing autopsies on that age. But they did find that already even at age 18, we're starting to build up plaque in our arteries. So this is not something where we wait until we're 50 and then we start building up a bunch of plaque. It's just like moving into a house that's a brand new house with clean open pipes. Those pipes don't get stuck and clogged up at the beginning, but they slowly start to build up things. And over the course of time, then we start ending up with more blockages or plugging because the pipes get roughened. They're not slick like they used to be. Now they're starting to hold or hang on to things. And so we slowly start seeing that buildup of gunk that happens. And then all of a sudden we've got plugged up pipes, right? So again, it's something that happens over the course of our life. So the earlier we get on this, the better. Do we have to always use medications early on? No, but understanding what is my body, what is my body type, and what is my genetics, again, makes a big difference. And I would say at least by early 30s, we need to be looking at this whole picture just to get an idea of what are our risk factors. So again, this is a blood test. It's done, it can be fasting or non-fasting with that one. We usually run it if we've had people with elevated lipids, we'll run that at least one time to see what their numbers look like. If lipids always look great, then it's more of a moot point, and I don't always run it. It's not an inexpensive study, but most times insurance will pay for it if you have high lipids. But again, I never promise anything with insurances. So that's always a case-by-case basis. So this is one of those examples where I talk about looking at not only just what does your lipid look like, but what is this as a result of. So this is one of those examples. This person obviously has an elevated total cholesterol. Their bad cholesterol, the one that's like teenagers dirty in the house, way too much of that. It's 161. Typically with a person with no other risk factors, that should be less than 100, and the total cholesterol should be less than 200. But if we have even one risk factor, we're pre-diabetic, we're overweight, we have a family history of cardiac disease, we have any other known cardiovascular problems, hypertension, peripheral edema, congestive heart failure, anything like that, and or pre-diabetes, diabetes, any one of those risk factors, that total cholesterol should be down below 150, and the bad cholesterol should be at least below 70. Type 2 diabetics, the American Diabetes Association just changed that regulation, and anybody with diabetes or high risk or post cardiac event, having had a stent or a heart attack or any of those other significant medical problems, that number should be below 55. So again, it puts it in perspective. This is not just a little bit over the normal, it's a lot over the normal, especially if this person has other risk factors. I'll come back to this person a little bit later, but when we look at these numbers, we look at the ratios, the total cholesterol to how much total cholesterol I have to how much HDL or good cholesterol I have to go around and clean up after it. If I have a higher cholesterol, but I have plenty of cleanup going on, I'm not going to get into too much trouble. And you can see with this person, we went from not being great to being better. Green is good, yellow is caution, and red is bad. So again, they improved their ability to pick up and clean up. The VLDL to triglycerides. Triglycerides, I'm not going to touch on as much this time. Triglycerides have everything to do with how we handle our sugars and our glucose, and very little to do with what we eat otherwise. So again, this person does not have a significant triglyceride issue. They don't have significant insulin resistance, creating elevated triglycerides. But again, triglycerides, the HDL does help clean up after that. That's that cleanup particle. So it does help with it. So they do look at how much HDL to triglyceride you have. Because they don't have too much of that triglyceride and they have a good amount of HDL, their ratios are actually okay here. The interesting thing is you can see we did some treatments. This person was able to drop their total cholesterol dramatically. They got it down below that 200 mark. The LDL got much better. The HDL did drop, but percentage-wise, it didn't drop as much. And that's why when we lowered bad cholesterol, we lowered it a lot more than we lowered the HDL. Once in a while, you'll see HDL can actually go up with some of the treatments, but it's typical if you drop it as much as this, that you'll see the HDL or the amount of good cholesterol drop a little bit, but we don't have to have as many maids if we don't have as many teenagers dirtying up the house, right? So again, it's not uncommon to see it drop. We just want proportionally for it to drop a lot less. And this person did. So they were able to improve some of those ratios. The very bad cholesterol to triglycerides, both of those were green. So I don't worry about this number if those are both fine. If those are out of whack, it tells you, is this more of a carb problem or is this more of a lipid problem? And that's what I use this number here for. So again, those are not good ratios, but they're both normal numbers. So I'm not concerned about that middle one at all. And I would probably just draw a line through it if you were in my office. So this is the one on that particular patient when we were looking at their bad lipids, we looked at whether or not they were a bigger producer or whether they were a bigger reabsorber. So this is one of those classic pictures where this person, you would not want to say, you need to go home for the next 6 months, try and exercise better, try and eat low fat, try and eat low cholesterol, get off all those lipids. What happens is people go home then and they stop eating the fats, which means they try not to eat. And so of course, then they start eating more carbs, which again, then are converted into sugars, which then drive up the triglycerides and drive us toward that end. But it doesn't necessarily help with the cholesterol at all because it's really mostly what this person is producing. So this is one of those classic situations, and we'll talk more about things that we can use for it, but we want to really block production. And that's what we did with this person. We gave them something to block production. We'll come back and talk about these two important numbers down here in a bit. But when we started blocking production, again, we were able to make an impact. And then we want to recheck that after a period of time. This was looked at in July. We looked again in October with this person on that medication. Typically, we like to look in about 4 to 8 weeks, which should have been about a month earlier, but that happens. Sometimes they come back a bit late. But this person was much better, but not quite there. So we were going to definitely need to adjust that dose so we get this LDL at least below 100. If they have other risk factors down below 70. So we still have room to improve on that, but we are doing much better with it. And again, we'll come back and talk about how these numbers have improved and what that means as well. But that's, again, how we choose. We need to shut down production, not just adjust diet or use medications that or food that bind it in the gut. That's not going to be the major benefit for this person. Okay. Any questions about that? Or if you guys have questions, you can certainly unmute and ask, or you can type questions in the chat box if anything is not clear or you're wondering about it. One of the other things that we look at is inflammation. And again, that's one of those things we're talking about. If we're shredding those vessels, everything gets more sticky, just like that sandpaper on my arm. So we want to make sure we're not getting that stickiness. And again, that inflammation is going to make a difference as to what my risk is. If I have vessels that are like Scotch tape, even if I don't have too much cholesterol, it's going to glom on and create more problems. If I have walls that are more like Vaseline instead of like Scotch tape, even if I have too much lipid, it may not have a chance to grab on. So that inflammation can make a big difference in both directions, even if I have a little bit too much. But if I've got good HDL that cleans up and very greased vessels, if you want to call it that, very non-sticky vessels, I'm going to worry about being a lot less aggressive than if I have very sticky vessels, even with not too much lipids. So again, those are two different situations and things where you would completely miss it if all you looked at was what we look at usually in your basic lipid panel. So reasons why we want to look at it. So HSCRP is that number that we look at to see how sticky are your vessels. We want that number below 1. If it's above 3, it's high risk, and if it's somewhere in the middle, it's somewhere it's halfway between those. Sorry, I don't know what I did there. But so again, we want to look at that HSCRP, and I'm just going to go back here real quickly. So you can look. This person, we looked at their HSCRP was right at 1. It wasn't below it, but again, as we improve the metabolic picture, we also were able to improve that stickiness. And so the vessels, not only do we have less cholesterol to stick on, but the vessels are a lot less sticky than they had been. So that's an important piece of making sure that we're not leaving sticky vessels with, especially if there's borderline numbers. And if this was your first time to check it, we'd say, oh, your lipids aren't too bad. If you were not on medicines, we'd say, oh, it's not too bad. And we'll just work on getting your HDL better and you should be fine. But then we could use this part down here to reassure ourselves, and your vessels aren't that sticky. So I think we should be in not terrible shape, and we can probably take a breath and work on this a little bit more slowly. These numbers, of course, when that was the first one, that was not the option. And we know that this particular person was already on treatment when we had this. But if they weren't, again, we could say, yeah, we need to work on that. but your vessels aren't terribly sticky. And we'll come back to this other number that would help us gauge how aggressive do we have to be with these lipids if that was our first time looking and we weren't on anything for those numbers. Does that make sense? So that inflammation becomes an important piece. We don't want sticky vessels. And those numbers can go up a lot. I've had people even up in the 15 to 30 range, just depending on how much we're shredding the vessels, how much leaky gut or things are getting across the intestine that we don't want getting past. So there's lots of things that can make that inflammation besides just glucose. Other autoimmune processes can make those vessels more sticky. So all of those things are going to make a difference. And then again, we want to talk about, do we have problems with having too much glucose? Again, anything that causes us to have even pre-diabetes, which is insulin resistance, where the sugar is not terribly elevated, but we don't handle or process it as quickly as we should. Or as that glucose begins to climb, then we're pre-diabetic or diabetic. Those things are going to really shred those vessel walls much more aggressively. And that's why, like I said, the American Diabetes Association for the first time this year says even getting that lipid number, the bad cholesterol, down to 70 is not acceptable anymore. We have to go down to 55 because, again, if we have very sticky walls, we have to have a lot less floating around in there so that we have less risk of things glomming onto the walls. So again, diabetes and prediabetes is one of those special situations where everyone with those diagnoses should be on a lipid medication if their bad cholesterol is not below 55. So at least below 70 for prediabetes and 55 for diabetes. But there are cardiologists that will take medications to get their numbers below normal, just saying, lower is better. And we'll talk about how low is too low. But again, we want to look at that. So when we look at that metabolic piece, one of the things we look at oftentimes is average blood sugar number, which is the A1C and blood sugar. This particular person actually ended up with a low sugar at times, which can falsely make your average look better than it is. So if I get highs and lows, my average may look okay. If I get highs and normals, my average will be high. If I get lows and normals, my average will be low. But if I get lows and highs, I can be in trouble. And that was what was happening with this person. They had a low or hypoglycemic situation in the mornings when they didn't eat. But after they ate, their sugars would go up a bit. We did find that out with sugar challenges, but their A1C looked fine. So had they happened to not have the low blood sugar there and a normal A1C, people in their office would be told, your blood sugar looks great, you're fine. Well, when we look at that, and again, I know this is our look at lipids, we'll talk about this more in another visit, but insulin, absolutely, if it's elevated in the mornings and our insulin resistance is high, it means that we are not processing or handling our sugars correctly. And this particular person is going to have much more of a metabolic problem, and they're going to have a lot more inflammation. I don't have it on this one, but this person's inflammation number, when we checked it in between these. So these were the basic screens that we did once we found that these were problems. We had done just an HSCRP and LPPLA2. Those were on a different form. And then we followed up later with these screens, and we'll come back to LP(a). But again, when we had treated these things, the HSCRP and the LPPLA2 both got much better. So that you'll have to take my word on, but it doesn't matter. This is just a matter of looking at this person did not have terrible lipids, but they definitely had an issue with a metabolic problem. So you're going to want to make sure that you're keeping these numbers more aggressively treated. And this LDL goal would be below 70 if you have these things going on. So again, it's a matter of looking at other risk factors when we make a decision on what is actually normal and not normal. So whereas we might have told people, actually, your numbers are pretty good, your HDL, you don't have quite enough MAIDs, but these numbers aren't bad, so I think you're fine. Well, that would all be good if we didn't have this little messenger here. And we'll talk about LP(a) in a minute, but that's a genetic predisposition to having a type of very dense protein lipid that will plaster itself along the arteries. And if this number is high, your cardiovascular risk is anywhere from 3 to 8-fold greater than people who have a normal LP(a) with or without abnormal lipids. It just means you have the kind that are very small and can erode and invade into the walls of the linings of the vessels very aggressively. And these people tend to get a lot more plaque and have very early development of cardiovascular disease. Again, it's one of those tests that should be done at least once. It's largely genetically determined, although there are things that we can do to make it somewhat better. But that's an important question. So this person, they say, your numbers don't look bad. But as soon as I look at this LP(a), that LP little a, like I said, at least once should be done. This person, I'm confident, would tell you they've got somebody in their family that had some kind of cardiovascular event earlier on in life, maybe in their 50s or 60s, had many people had to be on statins or had other cardiovascular complications. And usually that'll come out in a family history as well. But this one, if we're telling you everything's fine, we should at least be knowing what is your LP little a. And if that hasn't been looked at or checked at least once, and you've been treated for or are aware that you have other risk factors, that should be looked at least once. If that hasn't been looked at, make sure you talk to me or talk to your primary care about looking at it at least once. It can be done through Quest. Now they work with Cleveland Heart Clinic. I work with Boston Heart Clinic. They can also do it. So either or. So, so that's with our metabolic panel. We see those abnormalities, and then looking at that genetic risk factor for the LP little a as to whether we'll build up that plaque when we didn't expect it. And that little, that LP little a comes back to looking at that genetic determination for things that make us more prone to it. Also, if there are things that make us more prone to clotting or clotting disorders, that can also make a difference. So looking at for people that have a history in the family of early onset, or people that have had a history of any bleeding disorders, early onset clots, people who get blood clots when they take birth control, or have had issues with pulmonary emboli, those things can be also genetically predisposed, and looking at those factors can be important. This one I don't do on everyone. I look to see what is a person's risk factor, what is their family history, what kinds of things do we see in that, and are we looking at treating them with certain kind of medications that we're worried about? Might they have a reaction to? Do we need to look closer at a genetic issue, or do we not? But those things are something we usually hit on individually with people in the office, depending on history. There's a lot of things that can be tested. The downside with genetic testing is most insurances will not cover it. Some of the tests that we do tend to lean on, including the MTHFR, show up if people do that MEN23. In the past, they didn't do it, but the MTHFR gene deficiency for putting that methyl group on your Bs that we just touched base on, that's a genetic test that will show up on there. So some of those tests that we might look at sometimes are reported on the MEN23, and you can find out who your relatives were. But otherwise, Boston Heart, it usually at this point in time, I think is running about $60 for these tests. At some of the other genetic labs, they can run over $200 to $300 for the test. So again, being careful not to end up paying a lot out of pocket if you don't need to know the answer. But if it's helpful in making a decision on treatment, it can be really helpful. So just going to finish going through these here real quickly. I am going to have them send out this. This is a follow-up for anybody that would like it. Just call the office. We'll send you this little page here that talks a little bit about those definitions. The LPPLA2 is that last one that I want to touch on. And that's the one that tells me if I'm building up unstable plaque. And so again, I think I may have to go back in my slides here real quickly. So with the LPPLA2, when we lay down plaque in our vessels, it can either be hard or solid like a dirt mound, or it can be more liquid like a pustule. And let me just see if I can get back here really quickly. Come here. So it can be really hard like a dirt mound, or it can be liquid like a pustule. And if I scrape the top of that liquid one, the fat can go flooding into the vessels. And when that happens, the body sees it and forms a clot and stop it from flooding in. And so the key is that those unstable plaques are what lead to the heart attack or stroke. And that LPPLA2 is what tells us, do we have too much of those or not? So just kind of in finishing up, if I have that LPPLA2 and it's high, then I know it's just like if I'm in the ocean and I want to get across the beach into the jungle, I want to know, are there 10 landmines or 100? And I want to choose the beach that has 10. It only takes one in a bad place of these plaques to get us into trouble. But again, if I have only 10 versus 100, I'm going to be in much better shape. So looking at that unstable plaque, looking at that inflammation, those are two critical pieces, because if either of those are abnormal, you want to be much more aggressive with your lipids. And or if you carry any of those other metabolic risk factors or cardiac history, you need to be much more aggressive about those lipids. And those are the times we need to look forward. So again, looking at, look back there. Now we're getting there, sorry about that. So looking back at those those things, we'll just talk a little bit about this person. So we had looked at lipids. There would be no question this person needs to do something. But when we look at where their cholesterol comes from, it comes both from what they produce as well as what they absorb. So we could put them on something to block absorption, including statins, or we could put them on a bile sequestrant or a blocker in the gut. Putting them on a higher fiber diet would also help them absorb less. So we can hit it from both sides and make a bigger impact. Also, when we look at this person, they have a lot of inflammation. It's not over 3, but it is greater than 1. So we want to settle down that vessel inflammation. So we want to make sure we get on things to heal the linings of the vessels. And we look at that LPPLA2, they've got a lot of unstable plaque. We want that number below 180. Of course, below 120 is even better, but they're at 212. So this person already has unstable plaque that's putting them at greater risk. They have sticky vessels, which magnifies how bad these numbers really are. And then they don't have enough good cholesterol. They don't have enough maids cleaning up for as many teenagers as they have dirty in the house. So we don't have enough cleanup going on, sticky vessels, and higher risk with unstable plaque, partly because of these issues. And then we look at the fact they don't have enough HDL, but also look at how their HDL functions. Not much of it getting up to these upper numbers, right? So these are some of those numbers you saw before when I was looking at those individual pieces. But this person, we have to improve HDL function. We can block some of the absorption from the gut, but we also need to shut down production. And if we hit all 3 of those, we're going to make a dramatic impact on their health. So let me just see. So I'll just come back here real quickly. This is one of those people that has not great numbers here, a little bit of risk factors. This is at 184. We want it below 180. This one should be less than 1. So these need some work. These are not great numbers. HDL is pretty good, but is it working for them? And the answer is yes, it is. So that's why with 235 here and 161 here, not that far off of that other person, but these numbers are not nearly as bad. And it's because their HDL is much more functional. So this is one of those cases where it's really helpful to look at, is the HDL working or not, so that we know how aggressive do we have to be. And then when we look at this person, this is all production. So trying to do things that bind it in the bowel are not going to be as helpful. Changing diet, not as helpful. Not that we don't want to eat less saturated fats, sure. But again, we want to make sure that we're really hitting that production. And this person really needs to realize this is a production issue, and it really is going to require medication to shut that down. This is a person, that first quick look at those. This is a person where we took a quick look at, they were at 235 and 161. We started them on medication that blocked production. We got this down to 106. We got their good cholesterol came down just a little bit. But again, the total numbers look better. The ratios are definitely improved. As we said, they're looking better here. And that inflammation number is back to normal. And that unstable plaque has gone down to 154, down below that 180 mark. So we've controlled inflammation. We've lowered their cardiovascular risk by getting that LPPLA2. So those unstable plaques are much lower. So we've decreased the number of those and decreased the risk of getting into trouble. And so we see that shutting down that production has made all of that difference right across that line. And we see all those numbers getting better, which is always exciting. And I think this is just another, this is another percentage just showing sometimes we can have really good numbers, but the HDL is really bad. And again, this person has just very, very little of that. So even though their numbers don't look bad, their LPPLA2 shows you they're already getting into trouble. And this is a person in their 30s, but they're already developing unstable plaque, even though they might be told, your numbers actually look really good. Your LDL is fine, but you don't have much HDL, but just try and exercise better. You'll be fine. Well, this person's already not fine. They're already getting unstable plaque. The good news is they don't have a lot of inflammation. That's probably the only thing that's saving them, with nobody cleaning up the house. You can imagine, even if you don't have any teenagers around, the house slowly gets dirty. And if nobody comes in and cleans up, it's going to get dirtier and dirtier over the years. And so this is a big issue. So again, that's why looking at this LPPLA2 can help people understand, do we need to look further or do we not? Things that we can look at that make a difference with lipids, making sure that we maintain a healthy weight, watching how many carbs we eat, like we talked about the triglycerides, and not overdoing processed foods, making sure that we don't eat excessive amounts of saturated fats, but getting plenty of protein is still an importance. The omegas that we talked about, those healthy fats, help us heal and repair the linings of the arteries, making sure that we eat healthy fats. So enough of those healthy omega foods or omega-rich foods, and trying to decrease the saturated fats. We don't want excessive salt. If we're craving salt, we probably are missing a mineral. So looking at talking with someone about that, not just trying to not eat salt, but trying to get the correct salt on board, and making sure that we stay active is one of the best ways for keeping our HDL up and making sure that we burn through the cholesterol that we do have. When we start talking about medications, statins are the gold standard. A lot of people are concerned about, well, is that going to give me dementias or other things? The studies that have been isolated to use of statins and have isolated statins as opposed to other lifestyle changes, statins are the gold standard. They definitively lower cardiovascular and stroke risk, congestive heart failure, and do not seem to increase risk of dementias, although there were studies that showed that. It's really the microvascular disease from diabetes and from hypertension and poorly managed lipids that actually lead to the dementia and or the the brain issues. Dementia we now call type 3 diabetes. It's more related to how we process and handle sugars. But being aggressive with those lipids is critical for keeping those vessels nice and open. If you're not agreeable to or don't want to take statins, there are other ones. There's now things called PCSK9s, which are not related to statins at all. It's a newer class. They don't get out through the liver. They don't cause the muscle issues. So if you are one who does not break down your statins appropriately, there is a genetic test to look for that. Are you missing that gene from one parent or the other, or both? If you've had problems with statins before, you might want to check that gene. And sometimes doing just 2 or 3 days a week on a statin is tolerated because you can eliminate that. And if you take more, it'll build up, but it still has an impact. For women, there is only one of the statins that's been shown statistically significantly to lower those risks, which is rosuvastatin. So if you're a female being placed on it, make sure that you know that it's the correct statin. The binders are the ones that help us if we are absorbers, and ezetimibe or Zetia is one of those that binds it in the gut. So does a high fiber diet. It also helps. The fibrates are ones that help you not build triglycerides, but the most important thing to avoiding triglycerides is monitoring the carbs, and we'll talk about that in a different one. Bile acid sequestrants are the things that affect the bile that we secrete and whether or not we reabsorb it. So again, they bind the bile in the gut so we don't reabsorb it. So the ezetimibe and the bile acid sequestrants work if we are reabsorbers. And then making sure that we stabilize the metabolic problems. The fish oils help us heal the linings of the vessels, and CoQ10 is the fuel that the statins use in order to do their job. CoQ10 also helps our cells with mitochondria, which are the sanitation departments of every cell. If I use a statin and do not add CoQ10, I can pull CoQ10 from my cells, and therefore my cells can't clean up all the lactic acid and garbage that builds up. Therefore, I get more lactic acid and my muscles get sore or stiff. So if you are using a statin, you must give your body the right fuel so the statin can work. Statins are like the Pac-Man of the arteries that go around and clean everything up. But if they don't have fuel, they don't work. Or if they pull the fuel from the cells don't clean up either. So statins should always be used with CoQ10. And again, we can talk more with people individually if they're concerned about statins or other options. But those are some of the main things that we can use that help treat those statins. So again, I know we've run over just a little bit, but we were trying to get started and wait for people to join in. But thank you so much for joining. I appreciate it. I hope you've gotten some answers to questions you might have. I'm going to go ahead and see if I can turn off the recording. And we'll answer any questions anybody might have. So.